Dear students, I will explain some important points in relation to anti-Parkinsonian drugs. So to understand anti-Parkinsonian drugs, you should know what is Parkinsonism. So Parkinsonism is an extrapyramidal motor disorder characterized by tremor, rigidity, bradykinesia, with secondary manifestations like defective posture and gait, mask-like face, excessive salivation, dementia, etc. So if you want to see the pathogenesis of the Parkinsonism, main problem is there is decreased dopamine level in the striatum. So there is a structure called substantia nigra pars compacta in the midbrain and striatum. So striatum controls muscle tone and coordinate movement. And there is nigrostriatal pathway. So in Parkinsonism, there is degeneration of dopaminergic nerve fiber in the substantia nigra as well as in the nigrostriatal pathway. So as there is degeneration of dopaminergic fiber in the substantia nigra and nigrostriatal pathway, there is decreased dopamine level in the striatum. So we have seen the striatum controls muscle tone and coordinate movement. So there will be motor defect if there is decreased striatum or decreased dopamine level in the striatum. So there is an imbalance between dopaminergic and cholinergic system in the striatum, which will lead to motor defect. So although there is no change in the cholinergic system, but as there is decreased dopaminergic tone in comparison to dopaminergic tone, cholinergic tone will be increased. So there is an imbalance between dopaminergic system and cholinergic system. You can see normal individual dopaminergic tone, dopaminergic nerve fiber is like this, and in Parkinsonism there is degeneration of dopaminergic nerve fiber. So in comparison to cholinergic nerve fiber, dopaminergic nerve fiber, dopaminergic system will be reduced. So though the cholinergic system is not primarily affected, its suppression by centrally acting anticholinergic tends to restore balance between dopaminergic tone and cholinergic tone in the striatum. Now we'll see the pharmacologic strategies for dopaminergic therapy of Parkinson's disease. We can see there is a blood-brain barrier. So this barrier is present in the brain capillaries. So brain is protected from the peripheral circulation by this blood-brain barrier. So in the brain there is dopaminergic nerve. In the presynaptic nerve terminal, dopamine is stored in the vesicle, and from the vesicle it is released into the synaptic cleft, and in the postsynaptic receptor, dopaminergic receptor, this dopamine acts. Now this dopamine can be degraded by two enzymes. One is monoamine oxidase enzyme. Dopamine is degraded to DOPAC, that is dihydroxyphenyl acetic acid, and with the help of COMT it is degraded to 3-methoxytyramine. Now if we use levodopa in the treatment of Parkinsonism, levodopa in the periphery, it is degraded to dopamine with the help of dopa decarboxylase enzyme, and that dopamine, it cannot cross this blood-brain barrier, but it can produce adverse effects like there may be nausea, vomiting, cardiac arrhythmia, etc. Levodopa in the periphery also can be broken down to 3-O-methyl-dopa by COMT enzyme. There is a transporter, L-amino acid transporter. With the help of this transporter, levodopa enters into brain, and around only 1 to 3% of levodopa can enter into the brain, and remaining levodopa is degraded in the periphery. After entry into the brain, levodopa is converted to dopamine again with the help of dopa decarboxylase enzyme. Now if we use carbidopa can inhibit peripheral breakdown of levodopa by inhibiting dopa decarboxylase enzyme, but this carbidopa cannot cross this blood-brain barrier, so it cannot inhibit the central dopa decarboxylase enzyme. So central conversion from levodopa to dopamine cannot be interfered by the carbidopa. If we use tolcapone and entacapone, they also inhibit peripheral conversion of levodopa to 3-O-methyl-dopa. Tolcapone in addition can inhibit central COMT, so dopamine breakdown can be inhibited by tolcapone. Salicylin, rasalcylin, if we use, they inhibit MAO-P enzyme, so dopamine breakdown is inhibited. If you use bromocriptine, ropinirole, pramipexole, roticolin, these are dopaminergic agonists. They can directly stimulate dopamine receptor in the postsynaptic neurons. Unlike levodopa, you have seen the levodopa, it needs conversion to dopamine, then that dopamine stimulate dopaminergic receptor. But this dopaminergic agonist, they do not need to be converted to active metabolite. They themselves can stimulate dopamine receptor directly. So these are various drugs which can affect dopaminergic system. In addition to these drugs, we have mentioned centrally acting anticholinergics also can be used in the treatment of Parkinsonism. They do not affect the dopaminergic system, but they reduce the cholinergic tone. So dopaminergic tone and cholinergic tone imbalance is corrected. So this is all about drugs used in Parkinsonism. I hope you have understood. Thank you very much.